It is a pleasure to actually be here this afternoon, and believe it or not, the voice has sort of returned to normal. This is what happens when you take care of 6-year-old grandchildren the weekend before you're supposed to give a speech. So it's as good as it gets, guys. Sorry. So yes, we're going to start this process. I think the idea is if you are going to build a cancer center, what do you need to know? Where do you start? You know, what decisions do you have to make? Well, number one, hopefully you are involved as the physicist. Okay, that didn't move anything. Unfortunately, I have no disclosures. I would really like to have some so it could make life a little more interesting, but no, I have nothing to disclose. Okay, that is the astute group that met in Sweden a couple of years ago, and that was the actual end of a 3-year process to develop an international working standard, the equivalent of what NCRP 151 did for the U.S. So our working group produced what we call Standard 1664. That is the first international standard on radiation therapy shielding. I was the U.S. representative. I came over from ANSI. So I was the U.S. representative to this working group, and my major job was to keep the French and the Germans from killing each other. The best example I can use of how well that group got along was the day the German representative got up to go to the bathroom, and it was one of those doors that locks automatically when they left, and the French chairman looks at me and says, "I'm not opening that door. If you want to let him back in, go ahead." I'm not kidding when I said I was refereeing half the time. The Germans were insisting that we use the German standard because their data was far superior to anything anyone else had. Well, as an international standard, there's usually one requirement. You have to actually be able to get to the data. Oh no, that's private data, only published in German and only for German regulatory authorities. So I won the battle, guys. The good part is that is basically based on NCRP 151. So we did win a major victory on that. So if you can design shielding facilities in the U.S., you basically have the data to design facilities anywhere you want to all over the world. We pretty much have designed facilities pretty much all over the world at this point. So what do you actually have to decide when you're the physicist? Hopefully, like I said, you are involved day one. I think the worst places I see or the biggest disasters I see are when the administrators or the purchasing agent make the decision as to what machine to buy, and then they involve the physicist. Well, it may not even be the right equipment for what you want to do. So what have we actually changed? Well, obviously, in the U.S. at least, there's 2 manufacturers, Varian and Elekta, and as far as shielding, you just get their site planning guide, and it will get you started. But you have to decide, do you want a traditional LINAC? Do you want the brain, are you going to devote it to brain treatments only? What about tomotherapy? Do you want a CyberKnife? Do you want a Viewray? All these decisions have to be made. This or the Elekta equivalent, obviously the Varian True Beams, or I think Edge is now the newest one. But the Varian True Beam is pretty much the workhorse or the Elekta equivalent. You get 3 usually energies with a flattening filter and 2 beams without a flattening filter, which if you think, I'm looking at the age of this group, and maybe I'm the only one that's getting to this age, but I can remember when we bought linear accelerators that had 1 energy. At least I see a few other people that say, yes, we remember those days. And we commissioned them. It was really straightforward. Well, now you get to commission 5 beams, okay, plus all your electrons. So if you think it took you time to commission 1, now you get to commission a lot. For those of you that have residents, I think you're really fortunate because I can see where that would employ residents for a long time. But that's what you have to decide. What techniques are you going to use and with what energy? So what have we actually come from the days of a nice single beam linear accelerator? Well, we modulate the beam intensity, we modulate the dose rate, we do arc therapy, we do SRS, we do SBRT, we do every modality around. So decide what you're going to do. And then it might actually help if you talk to your physician, because they may have other ideas. What sometimes you will get in the middle of is what patient load your physician thinks you're going to do versus the patient load your administrator thinks you're going to do, because that administrator thinks you actually have to pay for this machine. And I think you heard part of that this morning, where you have to justify, what are you buying? It's clinical patient care. How many patients can you put through there? All the linear accelerators that I have seen being purchased today, everybody does one form or the other of IMRT. A lot of people now, in all honesty, just shield for 100% of the treatments at IMRT. We used to shield for 50%. You don't want to shield for less than 50% because I think everybody's doing VMAT or some type of technique of the arc therapies. What you have to know is what is your IMRT ratio, and that's the ratio that you have to put through in terms of monitor units to deliver a centigrade at the center, at ISO center. Typically, we use a value of 3. In step and shoot days, that used to be 5, and you'll notice with some of the modalities coming up, that ratio can be 15. What effect would that have? It doesn't affect your primary, but it affects your secondary calculations. So again, we typically will say at least 50% of those treatments are going to be IMRT, and sometimes you want to put 100%. So what you want to do is decide what's your IMRT factor and put that in for your leakage workload is what it's called. Not your primary workload, but your leakage workload, because that's what affects your secondary calculations. If you go tomotherapy or helical modulated radiotherapy, obviously you have a built-in secondary barrier because the machine is on basically like a CT scanner. So you don't really have a primary barrier. That's what makes those machines much easier to shield. On the other hand, you have really thicker secondary barriers. You only have 6 MV, which the nice part is, how can you shield with 6 MV? If you want to do that, you can add lead brick. You don't have to worry about neutrons. So we have places that put tomotherapy units in because that's sometimes the only thing that'll fit in the room. If you don't have room above your ceiling, they'll put in a tomotherapy unit. Sorry. Okay, so your shielding design is based on what fraction of the workload is at ISO center. What you really want to know is the frustrating part is in the booklet from the manufacturer, it says, oh, the leakage is only 0.02% of the workload ISO center. But will they give you that in writing? No. They will only commit to meeting the 0.1% of leakage. So if you have to meet the 0.1%, that's what you have to shield for as far as leakage. So it's consistent with the NCRP statement number 10 guidance. We typically shield for a tomotherapy unit to 3 gray of absorbed dose per treatment. I think that's fairly typical, but I stand to be corrected if somebody tells me different. They're larger treatments fractions than just unless you're going to use SRS and SBRT, and then they can even be higher, or they will be higher. Your IMRT factor for these machines is 16 monitor units per centigrade. So that's why I'm saying that can really affect your secondary shielding, because your leakage workload is 16 times as much as your primary workload at ISO center. What I'm trying to do is point out the factors that are going to be different than doing your typical straightforward one energy LINAC. And then I realize that is not a good picture, but it's as good as I had at this time, but I've seen better pictures. Then if you want to go to the CyberKnife, what is different about that? Well, it can aim at any of the walls, or at least a lot of the walls. Again, the good thing about a CyberKnife is it's only 6 MV, but it's on a robotic arm, so you're allowed to move it in any direction. You have a field size that goes from 5 to 60 millimeters at 80 centimeters. If you've ever done diagnostic shielding, dental units have a use factor of 0.05. That's the same factor that we use for a CyberKnife. We assume that any point on a given wall will only be hit 5% of the time. So you basically take the equivalent of what you've got in a primary barrier and you average it out and you spread it out over the whole wall, because the use factor is only 5% for any one point. The nice part is the back wall basically is secondary only. It can't point at that back wall. So you might be able to get away with a significantly, maybe a 2-foot back wall if you really need to. All treatments are IMRT on a CyberKnife, and again, their ratio is 15 monitor units per centigrade. So your leakage workload is really high on these units. Typically, we use a treatment of 8 gray for head treatments and 9.7 gray at 100 centimeters SAD for body or spine treatments. So you have a small use factor, you have a high monitor unit, and it affects both your primary and your secondary leakage workload calculations. Now, if you have that smaller field size, what does it do to your scatter factor? Well, scatter factor becomes almost negligible, because when we shield normally for a traditional LINAC, our field size is assumed to be a 40 by 40 centimeter. So you have a large scatter fraction off of that patient. When you do a CyberKnife treatment, because you have such small fields, your scatter factor is significantly smaller. And the ceiling is only for leakage, because you can't point the CyberKnife at the ceiling. So it really does save you some shielding. You can't point a CyberKnife higher than 22 degrees above horizontal. So that determines how high that thicker shielding has to go. And what I have later in the talk is some actual diagrams showing some typical plans that we've done for some of these types of units. Now, the fun has begun because we've now combined MRI with treatment units. When I put this slide together December, the Viewray system that was available was the one with 3 Cobalt 60 units in it. That's what's installed at UCLA. That's the one I'm familiar with. But what just got approved by FDA is the one that now has the 6 MV LINAC in it. So you are now shielding a 6 MV LINAC, and your MRI shielding has to be in that vault. And no, there's not 3 LINACs in it, there's only 1 LINAC in it. So what are we looking at? We're looking at higher workloads with all these new techniques. And what it does is it impacts your shielding materials that are used. What we're now looking for is high density concrete, lead, borated polyethylene. Any of these special materials don't get cheaper, okay? None of your expenses are gonna go down when you have to go to these special materials, but they enable you to actually build the facility. So, if you haven't figured this out, that might be a question on your SAM's question. What is the purpose of radiation shielding design? So the purpose of radiation shielding is obviously you want to reduce that effective dose from a LINAC or any other treatment unit to a point outside the room to a sufficiently low level as determined by your favorite regulatory agency for either the public or occupational occupancy. Guess what? If you miss that one, you're in real serious trouble. So what would go into calculating these radiation shielding requirements? The weekly workload of the machine at a specific energy. We're going to go through some examples here in a little while of how to specify a workload. The distance from the target or isocenter from the patient to the point being shielded. The fraction of time that the beam is oriented in that particular direction. And the fraction of time that the space under consideration is occupied. Again, I think you've probably heard those, but that's a good Sam's question. So, what are we looking at when we're looking at these locations to be calculated? You really have to look at every place that you could put a body, preferably a live body. But when you have all these locations, we label them simplistic, A, B, C, D. Every one of these different places, because these may, like here's your primary barriers, A and B would be your primary barrier points of calculation. All these others are secondary points of calculation. This is a semi-traditional maze vault, but I guess I would call it a short maze, like a very short maze. But this is typical what you will find. And for all these secondary beam locations, you'll have to calculate it for both scatter and leakage, and then for both photons and neutrons if you've got 10 MV or above. So all that makes life interesting. I honestly think it's probably been, I guess I get about 1/10 of maybe no more than 10% of our units that we get sent to do calculations are new construction. Far and away now, what we get are we have a 6 MV vault, we want to go to a high energy machine. We want to retrofit this machine. We want to retrofit this from here or there. Retrofits are a nightmare. They're a lot harder to do than straightforward calculations. For those of you that are residents that are getting ready to sit for boards, we don't ask you to do a retrofit on the board exams. You're only going to get asked to do new calculations. So the other question I get is, well, we have a little bitty dinky 6 MV room, and we want to put a 15 MV unit in there. We want to put a new true beam in there, right? Of course, Mr. Administrator's sitting there going ka-ching, ka-ching, ka-ching. I want to do it as cheap as I can. But of course, we don't have any way to expand the room, so we can't give up any space for this. So again, it's a compromise. What materials can you use? What space do you have available? So if you have space that's truly limited, you're going to end up with lead or steel. And there's compromises between that. The lead bricks have an advantage of having a TVL almost twice that of steel. Well, our TVL is half that of steel. But steel has the advantage of being significantly lower in photoneutron production. So, and also steel is much stronger. So a lot of times they will wind up using steel in the ceiling and lead on the walls. Ceilings are a problem. The issue of weight is your significant problem. You really don't want that chunk of lead to come down on top of you or anybody else. One of the hospitals in downtown LA, and I will not give it away totally, but it made the 5 o'clock news, was under construction to build their cancer center, and they were installing lead brick over in the ceiling. Well, they sent the job out to the lowest bidder, who apparently decided to undersize the steel bars that go, the rebar that goes in the ceiling that was supposed to handle all of this. And they had about 8,000 pounds of lead as they were installing when it all came loose. And it did not kill anybody, but it permanently put one installer out with back trouble that they will never work in the field again. It broke a couple of arms on a couple of other people, but they were very fortunate they did not kill somebody. And they did not take them to that hospital's emergency room, which is around the corner. They took them over to LA County and they waited for 5 hours before they were seen. So this wasn't exactly the best scenario, and that's why I'm saying you really have to watch these construction jobs, and hopefully they don't send it out to the lowest bidder. But the ceilings are a serious problem. So you wind up with some type of lamination between lead and concrete. And if you're gonna have to add lead to an existing room, are you gonna put lead on the inside or the outside? You're gonna put your lead on the inside of the room because you don't wanna have photoneutron production on the outside of your room. So you always add your lead to the inside of the room. If you wanna be nice to your patients, then you cover that up with a layer of borated polyethylene. The other thing you can have an influence on if you're looking at shielding calculations is, at least I've never seen that big a difference clinically between having a 15 and an 18 MV machine. But the difference in neutron production is significantly different. If you can keep them to a 15 MV unit instead of an 18, your neutron shielding is much, much simpler. So, what do we do with defining workload? From NCRP 151 days, it was straightforward. The time integral of the absorbed dose rate determined at the depth of maximum absorbed dose at 1 meter from the source. Easy peasy, right? We all specified 450 gray per week. Typical workload, 30 patients a day, 3 gray absorbed dose at ISO center per patient. NCRP 151 recommends you shield everything at the maximum MV. Simplifies the report. Quote, the lower MV has less impact on shielding. Okay, bet I don't have anybody in here that treats 100% of your patients at 15 MV anymore. Doesn't happen. That's what's changed between when NCRP 151 was published and how we treat patients today. We don't treat all at 100% at 15 MV. If you shield, I can guarantee you, if you shield your machine for 100% at 15 MV, you're gonna make some contractor really happy, and you're gonna spend a lot of wasted money, because obviously nearly a large percentage of your patients are treated at 6 or maybe 10. So you really do have to split your workload now. So here's your typical workload, how it used to be specified, all at 15, and we might say, oh, we had some IMRT patients in there. So we would use an IMRT factor at that time of 5 because it was again step and shoot method, and we spec'd it out at 30 a day. That's what's changed since 2005. Nearly all your machines today have flattening filter free modes on them, so you have your high dose rates. They have that gives you the higher instantaneous dose rate. Everybody has 3D ability, arc therapy. You have the potentially higher workloads. Everybody's doing IMRT, and thank heavens we now use about a much lower monitor unit per centigrade than your traditional step and shoot. I did get one request the other day that was the strange. I really thought the contractor had lost his mind when he called up, and he wanted me to do a shielding calculations for installing a used Siemens machine. And I said, no, nobody installs a used Siemens machine. Well, they actually are. So they do still exist, just not new. So today we have to talk about stereotactic body radiation therapy, your higher treatment fraction, if you do SRS, how many patients are you going to do per day? And then you have 2 or 3 MVs. So this is typically how we specify workloads today. Okay, you're going to do a workload for a 15 at 3D. You're going to have a 15 without 3D. You're going to have a workload at 10 for SBRT, for rapid arc, for 3D, and then for non-3D. And then again, you're going to have all those workloads for typical patients at 6 MV. This is how we do our calculations. You want to spread that workload out as realistically as possible so that you don't overshield your machine, but you want to adequately shield it too. I did get into discussion with a rather well-respected physicist the other day who was building a new facility, and they were going to build it exactly to the workload that they are currently doing. Well, that gives them absolutely no room for increased workload in the future. It gives them absolutely nowhere to grow if there's any techniques that change that take more monitor units. So I said, take what you're doing today and add at least 10% for the number of monitor units per week. Give yourself some room to grow. And I would recommend that too. Don't go exactly the way you're going to do today because you've got nowhere to go. Now, the other question we get is how do you shield your HVAC vacs, your ducts? This can be the biggest challenge around. We have to have ventilation and air conditioning into our rooms. We have to get it in there. Typically, it's located at the ceiling level, or ideally, I've seen a lot of them now coming through where they're putting it through the floors. And that works really well, too. Typically, it's right over the door, or if it's through a sidewall at a corner. You never, ever want to put your HVAC through your primary barrier. Contrary to what some architects will try to tell you. If you don't do any calculations at all, keep in mind that you put roughly a third of what you have in your door is what goes around your HVAC vac, your penetration. Okay, just if you've got 6 inches of lead in the door, you put 2 inches of lead around your HVAC duct. If you're going to do the shelf method, you want to extend it at least 6 feet from the surface into the room. So your primary barrier calculation tends to be, this is at least lessons learned from my surveys. I don't think you find it written anywhere, but typically your primary barrier calculation tends to be relatively accurate if your density is well controlled. If you know you have the right density of concrete, your survey measurements will really match very well to what you calculated. What you recommend is put a fudge factor in there. Don't ever shield it to the minimum. Put a fudge factor in there somewhere so that you have a little safety factor. We built the beautiful facility out in Rancho Mirage in California, 3 vaults. Well, I think they got the concrete from across the border. It was definitely lightweight concrete. There's no way that was 147 pound per cubic foot concrete. So we started doing all the measurements and it was all undershielded. So they wound up having to go through and put lead in there, at least in the primary barriers, to make it adequately shielded. So again, you really want to make sure they test that concrete, and standard weight concrete is 147 pounds per cubic foot. If you're doing estimates, default to 8 feet for your primary thicknesses if you have full occupancy, uncontrolled access. In other words, if you're dumb enough to put the secretary outside the primary barrier, that's what you would have to shield it to. Okay, but you can default to these values and at least it'll get you in the right ballpark for getting estimates. 7 to 7.5 feet is what you want in an adjacent vault, and any corridor that will all go for about 7 to 7.5 feet. If you have an exterior wall with no occupancy nearby, you can take that thickness down to about 6.5 to 7 feet. It'll save you thicknesses. You don't have to buy quite as much concrete and take out quite as much space if you can let occupancy work in your favor. And for conversions, roughly 1 inch of lead equals 6 inches of concrete, and 2 inches of steel equals 6 inches of concrete. Your typical secondary barrier, you don't really need a fudge factor. They tend to be, quote, conservative. So if you do them out of NCRP 151, your secondary barriers will be fine with no other conservative factors applied to it. You don't really need a margin on those. Again, if you've got full occupancy, I think you ought to go with full 4 feet. Now, if that's for uncontrolled, the other place I would say is put your 4-foot barrier, if at all possible, is between that treatment room and your control console, because that's where your staff's going to be. So I really like the 4 foot between the treatment room and the control console. Any of your other barriers you can get by with 3.5 feet, and on that back wall you can get by with about 3 feet. So again, you're playing with 6-inch increments, but it can save you quite a bit. Do not try to get inventive with your secondary barriers and do them in 6-inch increments. Your contractors will hate you. We had one physics report that literally gave the barrier thicknesses to the walls in 6-inch increments. There wasn't a contractor around that was ready to bid on that project. So you realize these are not the brightest bulbs that ever burned that are out there pouring concrete. You got to keep it as simple as possible so they can get it right. So this is how we typically specify the reports. You have your workload specified, and then down at the like the second part of the page is your primary barrier thickness. And what you want to show in your calculations is what you calculate versus what's permitted. And always you have to have your shielded dose. That shielded dose calculation obviously has to be less than what's P over T is permissible limits divided by occupancy. So this column has to be less than that column. Now, that's why I said I was going to give you some examples of why life is not as simple as it used to be. Remember the days in NCRP 151 and you have a simple square room with a single maze. I haven't had one of those in a long time. If anybody wants to give me one of those, I'll be glad to shield it for you. This is typically what we get. Oh, we want to stick a LINAC in this medical office building. Is that a problem? Yes, it is. Okay, so we have no room to do anything. So what we wind up giving them is all these different increments. But what I'm saying, and notice is this is your 240 pounds per cubic foot of concrete. Go with your high density concrete is still cheaper than going with lead if they can get it. What you wind up with a lot of times is, or what I recommend, is if you've got to go with one of these sections, it's the high density concrete, look at your manufacturers that'll give it to you in blocks. It's like constructing Legos. They precast them, they control the density, so you know you're getting what you specify, and they just layer them up. Okay, it's like literally constructing Legos, but it works really well, and you know it's actually the specified density. So this is where we went with this, is this is all 147, but this is 240. So this is your primary barrier, and that's driven because this is all this is the limits of the building. They didn't have room to go out there and go extra feet. So that's what you wind up doing. Now, what else is different about this room compared to the traditional maze LINAC? There is no maze. I would say well over 50% of our rooms now do not have mazes. Most people are going with these direct doors. And this is a single sliding door. See, there's your door slides over. Actually, what's really nice is I think all 4 vendors that make these shielding materials all offer bi-parting doors now. So the doors look like you're going into a mall. You walk up and they just open. They're bi-parting. And so the patients love it. They don't feel like they're going in. It's not as scary to them to come into their treatment room because the doors open like a normal door, like you're used to walking into. And so that works real well. The one I didn't understand was the one that we did the other day, and they had the bi-parting doors, Well, this one's not a whole lot better, but they opened them right in the center. Well, that's fine, except when you get through with the treatment, that patient is laying there on that table, spread-eagled for all the world to see when that door opens. It wasn't really very smart. You know, it would be like, so you got to think about all aspects. Where's that patient going to be and be observed? So it's much better if you can put your opening off here to the side so that somebody walking by here doesn't see that patient when that door comes open. What they had to do was actually go through and put a little partition there so that the patient was not visible to the general public walking down the hallway. So there's pluses and minuses to some of these designs, but that's what you can wind up doing is using your HD concrete, using your sliding doors. And what I'm saying is, look at the space. This is a fairly compact space. It takes much less room than doing a traditional maze linac. Then you give very good details of what goes in that door and what we call the details around the sliding door, how much it has to overlap. You want hopefully at least 9 inches of overlap for each one of these sides of these doors, because otherwise what happens is your primary beam comes right through here and misses the door and goes through there with no shielding. Now, your challenge can be your ceiling. This is what I call the nightmare ceiling. You can't have a bump out. It was an existing building. So you can't do your traditional bump out. You can't do a bump down because you hit the linac. You have to have room to rotate the linac. So if you can't bump up or you can't bump down, how are you going to get the shielding in there? Well, you have no choice except to go with the high density concrete or lead to make up that thickness. You can do a 4-foot ceiling all the way across and do it with about 13 to 14 inches of lead and the rest of it concrete, and you can make one uniform ceiling thickness of 4 feet all the way across. So this is what I typically will give the contractors, is like the primary thickness in the center, and then space it out, feather it out, because you don't want to buy more lead than you have to. So as you go off center, you can go down in your extra thickness of your lead. And that's just, this is an example that we did with a lead brick, and I call it feathering. So in other words, you start thin, you add the lead as most you need it, you feather it out, and this was obviously an adjacent vault. This was a section with 3 vaults in a row. So you feathered it up, you feathered it down, and then you feathered it up again. And so again, we'll do that usually in 6 or 12 inch increments, because these lead bricks are 6-inch bricks. And so you can add it up to that point. Here's a Viewray room. The door must have 7.5 inches of overlap between the lead and concrete in the wall when closed. And we also assume that you've got no more than 1/2 inch gap between the door and the outside wall. And then the door in this one has 7 inches of lead in it. Again, it's only 6 MV, so you have no neutrons to consider with a Viewray. It's just a 6 MV unit. But this one's going into Miami. And so it's our first Viewray with the 6 MV in it. So it works real well. You can do it all with lead brick. And again, it's a fairly small room. So if you're really challenged, you may be looking at some of these newer units to be able to fit them into a small room. You want flat surfaces, because realize they've got to get the MRI shielding. Your RF shielding has to go inside your X-ray shielding. So you want flat walls. You don't want these bump out walls. You either want the bump out on the outside, or you want to do it with HD concrete or lead in your ceiling. But they've got to bring your RF shielding for your MRI unit has to be inside all of your X-ray shielding. This was a Cobalt Viewray. Again, small room, small footprint. This one was really straightforward. It was just fit right in this nice little square room. Here's your leaded RF door. And that was that description. They wound up actually, and then here is your sliding door. Your tomotherapy room in a former 6MV vault. You want your nightmare shielding project? Try this one. But this is what I put it up there because it literally was a nightmare. We have had the privilege of getting to design the shielding for all of Cedars Sinai's retrofits. Do you know how long Cedars Sinai's been around? A long time. Those rooms are like patchwork quilts. Okay, they got a little bit of lead here, a little bit of lead there, spaced out all over those ceilings. So when you wind up doing those, you wind up doing crazy things like this. You need a little bit of lead here, you need a little bit of lead there, and then space it out all the way around. And this is what, like for Tomo, this is where all the different points of calculation, you had to do every one of these and show that every one of these individual points was actually shielded so that this shielded dose rate is less than the permitted rate. CyberKnife installations, this was the one that went in, I think this is the one in Alaska, and they converted what was a CT simulator, not a CT, the variant version of the traditional simulator. They had a traditional simulator in this room, and they took that out and put in a CyberKnife. So you can make strange conversions, but it worked. But that's the only way they could fit it in, is to put it at an angle. And so it's in there. It's just your primary barriers wind up being here and then over around the side. Okay, what I put in here are some information I got from Nelco, and I'll give them credit just because they're the ones that gave it to me. There are 4 vendors basically that supply this equipment and materials, but Nelco was nice enough to go through and give me the calculations, because what I wanted to show you was what the cost is for just using what they call the Megashield block. This is a very popular option lately because everybody wants things fast now. Nobody wants to sit around and wait on concrete for it to cure. So what you find happening now is they'll build it out of these precast blocks. And these are like big blocks, okay? There's little blocks and there's big blocks. But you can get Megashield blocks that are like 3 foot wide. So it's like literally stacking up Legos 3 foot at a time. And these rooms, there's no curing, so you just stack them up. So they construct very quickly. And traditionally, that's why it was straight 147-pound concrete. But look at the size. You need an exterior area of 32 by 36 feet to be able to get a 20 by 24 foot inside, and that's what your manufacturers tell you they want. Construction cost for this vault, though, is less than $400,000. That may sound like a lot of money, but realize this is the cheapest option you have. So again, think back to this morning's class when they were talking about justifying a cancer center. Radiation therapy is now going to be a cost center, and so to do any of this construction will be a significant chunk of change. So if you're looking at $400,000 for the vault, and you're looking at another up to $100,000 for the sliding door, you're now into $500,000 just in construction cost to build a vault. And then you've got another $10,000 to $25,000 for your your ventilation shielding. So roughly, as far as budgeting, you're talking roughly about $500,000 for vault construction, and that would be your cheapest per vault design. If you have to go to using what they call the hybrid Megashield, where this is your HD concrete, the HD concrete sections, it's going to be a little more expensive. So your basis, when you get rid of those primary barriers and do them all out of, when you do it out of HD concrete, is what I'm seeing is your cost now went from $525,000 to $575,000. So you just basically added another $50,000. that may be fine. Just realize that it is going to cost you as soon as you start going anything other than straight concrete. So if you did the high energy machine, this is using the, I shouldn't touch two things at one time. Okay, when you have to go to using the 288 or 300 pound concrete, those are the really heavy blocks that your contractors do not like you at all for, but they will do it. And your cost for using one of those vaults made out of your HD concrete totally is about $750,000. So I thought those were numbers that I didn't necessarily have, and I appreciate getting that information, but that's the kind of information that sometimes you're the only one that will have that kind of information. And they'll look at you as the expert and say, how much is it going to cost me to build this vault? So it's roughly, if you have to do it out of HD concrete blocks, you're looking at about $750,000. And then you add another $100,000 on for that door. So it can easily get up to close to $1 million in construction. So, in conclusion, you really are gone are the days of simple, easy shielding design. At this point, I think I've designed about 500 vaults all over the world. We do an awful lot of construction design, somehow throughout Ireland, England, all the UK. Somehow we got really into Europe. We've done several in Saudi Arabia, Dubai, lots of interesting places over there where they build complete vaults, okay? 3 of them. You can't treat the men and the women on the same machine, so then they turn around and exactly duplicate the vault designs. So they'll build 6 vaults for what we would build 3 vaults, because they literally duplicate an entire cancer center for male and female, because they will not treat the same machine, treat patients on the same machine. So when you get those kind of jobs, you get really good at doing shielding design. Kind of crazy. The biggest thing I can say, the biggest challenge we have is getting accurate data for the workloads. That's your major determinant for your shielding requirements, and it's the hardest data to get. I really like to work with the physicist that's going to be there or is currently there. I will always work with you. I would recommend, if you do shielding design, make sure you work with the staff physicist to get a realistic estimate for workload. The physicist is going to know more than the EMD or the administrator. Contrary to what they may think, you know more. And then work with your architect as early as possible, because you have to know what your hard limits are for size of your room that you have available. Other than that, I gave you my contact information. All these slides are going to be available on the web. It's on there as a handout. So if you need anything, call me. I will be glad to walk it through with you on any construction calculations or shielding calculations. Like I said, I've done about 500 of these vaults now, so I've seen an awful lot of them. I would be glad to help anybody at any time that you have a question. And thank you very much. I think we may have 7 or 8 minutes for questions if we want, or else you can move on to entertainment known as George. Yes, sir.
Can I ask a quick question?
Sure.
I just finished one under shielding and redesign to replace one of our 21EX by TrueBeam last week. And I discussed with one of our colleague physicists, maybe one thing I want to check with you. When we design the workload, how do we count the QA workload? From your NCRP 151, they recommend if the QA was done in the normal working hours, then we also should consider some QA workload. But it's, my other colleague physicist, his point is maybe QA mostly done either after 4 o'clock or in the lunchtime or in the weekend, also done by a physicist. We might be shouldn't consider that into the workload. Then these things, I'm a little bit confused.
The workload, I think the question is, how do you account for the QA workload? And basically, that is considered unfortunately for us, most of the time to happen outside the normal 40 hours that you're treating. And so if it happens out of any 8-hour shift, you don't account for it. It's in a different 8-hour shift than what would be accounted for patient treatment. So you don't add your QA workload to your patient workload because it's basically going to be done at a different time frame.
But in the morning QA, you thinking the therapists have to do in the morning QA every day,
Right.
They start on the 7:30 or 8 o'clock, including in their.
I would just treat it as a patient treatment. I don't think we do not specifically account for QA workload. I guess I'd just put it that way.
Okay, thank you.
Excellent talk, thank you. I had a question about when you're reusing an existing LINAC, you're talking about places where they've undergone multiple iterations of that room. In those situations, how do you arrive at the right thicknesses of materials that are already existing? I've faced some similar situations, and it's always hard to rely on drawings. You don't know how good they are, how current they are. So do you typically, get a coring sample, something of that sort?
The question is when you don't have the real drawings. In other words, you can't get old drawings, correct?
You unreliable drawings, let's say, or you don't know how good.
If you don't know, okay, ideally, we had this situation the other day where they didn't know whether the drawings were correct or not. They still had the old linear accelerator in there, and we had to make some transmission measurements with the existing linear accelerator because you can back calculate to how thick that is pretty much based on those measurements. If not, you have to pretty much decide. We do go off of the latest architect drawings that we can get. We also have had them core through a wall and get a sample and see how thick it is, but that's an expensive process, and then you have to figure out how to fill the hole. So I would really recommend you try to get some kind of estimate of how thick those walls are. Yeah, Gary?
I wonder if you run into the situation we did once in which the hallway behind the accelerator vault that I had calculated as not being full occupancy, later I walked out and saw a whole bunch of cubicles there. So I've become leery about assuming less than full occupancy in a lot of situations. I wonder if you've run into that sort of thing.
Oh, the change occupancy of all kinds of things. The administrator walks in, the administrator's office is now what was told you was going to be the dirty linen closet. Yeah. The easiest way is obviously assume that it's full occupancy, but reality is no, we do use occupancy. I pretty much take the architect's word for it and basically put the caveat in there that if anything changes in terms of occupancy or workload, you have to do a recalculation. I think that phrase has to be in any report that you have. But yeah, if you know a situation like that, you're going to have to re-shield it probably. It's very expensive. That's true. You try to hide. You don't see it. Yeah, Jatinder.
So, Melissa, thank you for a wonderful talk. One of the things that didn't come out, which I think is becoming increasingly a problem, is the size of the room. Typically, to get all of the functionalities of a modern-day linear accelerator, there's a minimum size that you require because of all the imaging and the camera systems that we have. And the vendors will sell you any machine to go into any room. So are there any recommendations or anybody looking at what is the minimum vault size that to get complete functionalities of a linear accelerator?
The vendors will give you the minimum. I would exactly agree with you. I would hopefully not design a room to a minimum size room. You really need that extra space to put all that extra tracking stuff in there. Most of the vendors, both of the vendors, at least Electa and Variant, will give you recommendations for bigger rooms, but what they spec out is the minimum, and you really don't want to build that room to the minimum.
So we've gone on the limb in the VA and basically said that no room should be smaller than 24 in the longitudinal direction and 20 in the width.
Yeah, 20 by
As a
24
clear,
is pretty much the default minimum. that you'd recommend for a room. Yeah.
Thanks for a very interesting talk, Melissa. I have a question. The question is that you design the room for an 8-hour shift, and the clinic gets very busy, and they add a second shift, and they work till 10 o'clock at night. What is your advice on this situation?
You shield it for any 8-hour shift. That's still true. The workers are going to work 40 hours. It really doesn't matter whether they work 4 10s or 3 12s or however you do. You're only shielding for any 8-hour shift. And where this comes into particularly is we do the shielding designs for Varian and for Electa's test vaults, test cells, and those run 24 hours a day. So again, we are shielding those for what they will do in any 8-hour shift, not the fact that they run them 24 hours.
Okay, thank you.
Okay, thanks, guys.